Hello and good evening, everyone. So how are you all doing? I hope all of you are fine. Okay. Okay. So welcome to another live session on Eden 2. So for our regular batch, we had started a new subject this week. It is general pathology. So if you look at the NEET MDS question paper, general pathology together with microbiology, you can expect a total of like 14 questions for your NEET MDS examination. And from general path alone, you can expect somewhere around like 6 to 8 questions. On an average, you can expect around like 6 to 8 questions. Okay. So if you look at the pattern of these questions that were generally asked in this general pathology, uh, most of them, okay, around like 50% of them can be like direct factual questions, uh, like the straightforward one-liner questions. Okay, they are commonly asked. And other than that, you can also expect clinical-based questions and image-based questions also. Okay, so keep practicing more and more of clinical-based and image-based questions, then only you will get a hang of it. Okay, like you will know how to solve the question by regularly practicing. Okay, so like general pathology, like I had already mentioned, it has like lots of overlapping topics with general medicine also, like the infections and the systemic pathology part and all are like overlapping with general medicine. So you can study both these subjects together so that you can cover a wide variety of topics together. Okay. And if you look at it, if you like go through the previous year question papers of general pathology for the NEET MDS examination also, you can see that there are like some favorite topics of examiners from where questions were frequently asked. Okay. Like, for example, necrosis. Okay, necrosis is like a favorite topic of examiners. Even for this NEET MDS 2025 examination also, there was a question on fat necrosis and all. So it was frequently asked. And next one is genetics. Okay, genetics is like a very favorite topic of examiners. Definitely one or two questions can be expected from genetics alone. Last time it was like an image-based question on reciprocal translocation. As this time, they had asked a question from like a pedigree chart. Okay, the pedigree chart was not given, but they had asked like if autosomal recessive mother and a normal father has offsprings, and then how many percentage of them will be affected, or like all 50 percentage will be carriers, or all 25 percentage of the children will be carriers, or something like that. The question was asked. And so necrosis, genetics, then infections. Okay, especially tuberculosis and HIV and hepatitis B. Okay, very favorite topics of the examiners for general pathology: HIV, TB, and hepatitis B. Okay, please don't go to exam without looking at these three topics. Okay, then yeah, that's the, as for now, that's the high yield topics you can expect from the general pathology. Like questions can be different every year, but the topics, okay, the topics from where these questions were asked, they are like almost similar for general pathology. And like I had mentioned, these are some of the favorite topics. And thromboembolism also. Okay, thromboembolism and heart failure cells were all like questions asked this time. And the cells which form the atherotic plaque, what cells form the atherotic plaque, whether it is macrophages or like dendritic cells or other mast cells or some inflammatory cells were given. Okay, so such kind of questions were frequently asked in general pathology. Okay, so for today's session, we'll be mainly concentrating on the first few basic chapters of general pathology. like the cell in health and disease, about inflammation, immunity, and hypersensitivity, and about healing also. Okay, so we will mainly discuss the questions related to these three topics. Okay, I had included like both the direct factual questions and the clinical based questions in this session. Okay, and so that you will know how to you will get an idea about the pattern of the questions that can be asked for general pathology. Okay, so let's start, doctors. So first question, which of the following cycling is associated with G to M transition in cell cycle? Is it cyclin A or B or E or D? Okay, so first, to know this, you should have an idea about what cell cycle is, what is happening in the cell cycle, what are the stages or the phases that is present in the cell cycle, and you should know about what are the cell cycle activators and what are the cell cycle inhibitors. You should have a general idea about all these topics. Okay, so let's discuss from the basics what a cell cycle is and what are the stages and everything related to cell cycling, and then we'll have a look at which cyclin is more involved in this G to M transition phase. Okay, so yes. So if you look at the cells in our human body, they are continuously dividing. Okay, most of the cells are like continuously dividing or proliferating each proliferating cells. Okay, so why this they are continuously dividing or proliferating? Because to for the maintenance of the body, for the growth, and for regeneration and repair, and for all those purposes, the cells are continuously dividing. Okay, so these sequence of events that results in the cell division, that is called as this cell cycle. Okay, so cell cycle is a cycle where the cell goes through while its division process. Okay, so during its division process, the cell undergoes through a series of events. Okay, so that is called as this cell cycle. Now, this cell cycle is mainly has like 5 phases involved in it. The first phase is the G0 phase or the gap zero phase, or which is also called as a quiescent phase or rusting phase. Okay, so this is like a rusting phase of cells where they don't divide at all. Okay, so that is the G0 phase. Then you have the G1 phase, which is called as a pre-synthetic growth phase. Okay, so pre-synthetic growth phase means the mRNAs and the proteins for the DNA synthesis are they are getting produced. Okay, the cell itself is getting prepared for division. Okay, so that is what is happening in the G1 phase. Mainly the mRNA and the proteins are getting synthesized for DNA synthesis. That's what's happening in the G1 phase. The next is the M phase or the next is the S phase. Okay, S phase is the synthesis phase. Okay, so synthesis phase is where they start producing the nuclear DNA. Okay, so this is a very important phase because no error should happen at this phase. Okay, if there are some errors that happens at this phase, then that will result to like imperfections of the DNA, mutations in the DNA, and all those complications can arise. Okay, so this synthesis phase is the phase where the cell produces the nuclear DNA. Okay, the next following the synthesis phase is the G2 phase. Okay, which is the gap 2 phase or the pre-mitotic phase. Just before the mitosis, a special phase is there, which is called as the G2 phase. It acts more like what to say, they are checking whether the DNA that is produced in the S phase is like proper or not proper. Okay, if it is not proper, then they correct it at this phase. Okay, so some kind of corrections are happening at this G2 phase or pre-mitotic phase. And after necessary corrections are made, then only it will go to the M phase or the mitosis phase. Okay, so mitosis phase is where the actual cell division happens. Okay, so based upon the capability of cell division, the cells are divided into 3 types. You have the labile cells, which are like continuously dividing cells, like the squamous cells and all. They are like continuously dividing cells. And then you have the stable cells, okay, like the hepatocytes. They will not be continuously dividing, but when a need arises, they divide. Okay, so those cells are called as the stable cells. And then we have the permanent cells. Permanent cells do not divide at all. Okay, example is neuron cells. Okay, so neurons. Okay, they don't divide at all. Okay, so this is the general picture about the cell cycle, the stages in the cell cycle, G0, G1, S, G2, and M. Okay, so these are the stages in the cell cycle. And then based upon the cell division properties, the cell can be divided into labile cells, stable cells, and the permanent cells. Now, this a whole cycle we have seen. The cells will be undergoing or going through this cycle regularly. Okay. But there should be some checkpoints or there should be some limitations for this cell cycle also. Okay. So we have something called as cell cycle activators and cell cycle inhibitors. Okay. So like the name suggests, cell cycle activators means the ones who activates the cell to go through this cell cycle. Okay, through this cell division process. Okay, so that those activators are mainly cyclins and cyclin dependent kinases. Okay, so these two are the activators of this cell cycle. Cyclins and cyclin dependent kinases. Okay, both of them are, if these proteins are present in the cell cycle, then the cells will continuously, regularly go through the cell cycle. Okay, so that's the main role of this cyclins and cyclin dependent kinases. Next, we have inhibitors. That is, there should be like not too much proliferation of the cell division also. Okay, like happening in a tumor, there should be not too much proliferation. So there should be a checkpoint for that too. So there we have the inhibitors also. Inhibitors means they make sure that the cells are not like continuously proliferating and not going to tumor stage. They are checking that. Okay, so the inhibitors are mainly the CDK inhibitors. Okay, cyclin dependent kinase inhibitors are there. Okay, so the activators, let's look at the activators, cyclins and cyclin dependent kinases. Cyclins, around like 15 number of cyclins were discovered, but the main important ones are D, E, A, and B. Okay, and the cyclin dependent kinases that are important are 1, 2, 4, and 6. Okay, so this is the general picture of the cell cycle, including the activators and the inhibitors. Okay, so you can see that it is more like a relay race. Okay, so when this cyclin D comes and gets attached to this CDK4 here, then only the cell will go into the from this G1 phase to the S phase, like that. Okay, and when the cyclin D is getting attached to the CDK6, then only it will move on to the next phase, that is the S phase. Okay, more like a relay race that is happening here. Okay, so if you look at it from G1 to S transition, the cyclins and the cyclin dependent kinases that are dependent on it are this D and CDK4. Okay, then we have the cyclin D and CDK6. And then we have the cyclin E and CDK2. Okay, so if these three cyclins are there only, the cell will move from G1 to S phase. Okay, I hope I'm making myself clear. Okay, and in the S phase, which all cyclins are needed are, one is cyclin A and CDK2 and cyclin A and CDK1. Okay, if these cyclins are present only, it will move from the S phase to the next phase, that is the G2 phase. Okay, so from G2 to M, the main cyclin that is involved is this cyclin B and CDK1. Okay, so in the question, it was asked like, which of the following cyclin is involved in this G to M transition in cell cycle? Okay, so G2 to M transition in cell cycle is mainly mediated by this cyclin B. Okay, so in case of any doubts, it's a little bit complex to understand, but once you understand it, it will be very easy for you. Just remember this diagram alone. Okay, when you remember this diagram, it will be much easier for you. So the one that is involved in G2 to M transition is mainly the cyclin B. Okay, remember that. Now, next question. The term pluripotency indicates. Okay, what do you mean by pluripotency? Is it the ability of the cell to differentiate into all cell types of the body, or the ability of a cell to differentiate into any cell type of a specific lineage, or the ability of a cell to self-renew and produce more stem cells, or the ability of a cell to differentiate into only one specific cell type. Okay, so to know or to describe about pluripotency, first you should know about stem cells. Okay, and the different types of stem cells. Okay, so stem cells are the what to say, the primitive cells. Okay, they are the most immature cells, and they have the potential to differentiate into any specialized cell. Okay, with a distinct function. Okay, the main stem cells, if you consider, they are like the primitive cells in the like the organism formation stage. Okay, like the zygote. Okay, zygote can be considered as a stem cell. It continuously divides, and uh, when these cells continuously divide only, it after a few after it gets after a specific period only, a specific function for that cell is assignated, and then only it will produce a particular group of cells. Okay, so the cells that are in the initial stages of the development, like the zygote and the morula and all those things, are like primitive cells, which are immature cells. Okay, so their main function is like to continuously divide. Okay, so there's such type of cells are called as the stem cells. Now, if you look at this, these stem cells can be of two types. We have the embryonic stem cells and the adult stem cells. Okay, so based upon the potency means what you can say, their ability to form the cells. Okay, you can tell them like that. Okay, their ability to produce new cells. Okay, so that is called as a potency. So based upon the potency, these embryonic stem cells are actually included under totipotent stem cells. Okay, totipotent stem cells means they can differentiate into both embryonic and extra embryonic cell types. Okay, almost all the cells from our human body is produced from these totipotent stem cells only. Okay, they can produce embryonic tissues and non-embryonic tissues also. Okay, then coming to adult stem cells like the pluripotent stem cells or the multipotent stem cells or oligopotent stem cells and the unipotent stem cells. Okay, as we go down this line, we can see that the cells are getting more and more specialized in nature. Okay, at the topmost area, that is the totipotency, the cells will be completely non-specialized cells. Okay, but as we go down, the cells will be more and more specialized in their function and specialized in their division process also. Okay, so that is the main characteristics of these cells. So pluripotent means it can generate all cell types in an organism. Okay, like the inner cell mass of the blastomere. Okay, that can be considered as an example of pluripotent stem cells. It can generate all cell types, can produce the all germ layers also. It can produce ectoderm, endoderm, or mesoderm. Okay, then multipotent, again, the cells are getting specialized. Okay, the ability of a cell to differentiate into any specific, only a specific lineage. For example, ectoderm. Okay, ectoderm will produce only the ectodermal structures like skin, hair, nails, etc., teeth, all those structures only. Okay, so again, the cells are getting more specialized in this multipotent stem cell area. The next is the oligopotent stem cells. Oligopotent means the ability of a cell to differentiate into only one specific type. For example, if it's just the skin cells, then they will only produce the skin cells. Okay. Unipotent stem cells, again, more and more specialization, the ability of a cell to self-renew. Okay. So basically, the basal cells in the epidermis. Okay. The basal cells in the epidermis and all, they'll just self-renew and produce more stem cells. Okay. So this is the like the hierarchy of stem cells, you can say, starting from totipotent stem cells to pluripotent stem cells. So in the question is, it was asked like, what do you mean by pluripotency? So it is the ability of a cell to differentiate into all cell types of the body. Okay, it can produce all three germ layers, these pluripotent stem cells. Okay, so this is the basic hierarchy picture you can see. Yes, the inner cell mass of the blastocyst. Yes, that is the pluripotent stem cell. It can get differentiated into ectoderm, mesoderm, and endoderm, which again will form the more specialized cells. The next question, patterns of nuclear changes in necrosis include all except. Okay, So they were asking about the changes that you see in, excuse me, that you see in necrosis. Okay, so what is necrosis? You should know. And what are the cytoplasmic changes that is happening in necrosis? And what are the nuclear changes that is happening in necrosis also you should know. Okay, so let's first discuss about necrosis. So necrosis is like death of tissue, okay, or a death of cell, okay. Usually it is always pathological only. So what is happening in the necrosis is that because of some kind of injury to the cell, usually when some kind of injury happens to a cell, what the cell tries to do is that they recognize the injury and they try to repair it and try to get back to normal. Okay. But if the injury is like persisting, okay, if the injury is keeping on persisting and it is keeping on injuring the cell, then what happens is that it will go into a condition of like irreversible cell injury and necrosis. Okay, so there what happens is that the cell will die because of this persistent injury. Okay, so such type of cell death is called as necrosis. So in necrosis, usually what happens is that there can be the cell will enlarge and it will lose the marginal integrity. Okay, so we have the plasma membrane covering for the cell. This plasma membrane will get like broken down at places. So it will give like a moth-eaten appearance. Okay, if you look at it under the microscope, it will give like a moth-eaten appearance and the contents of the cell will just leak out of the cell and lots of inflammatory cells will come also and it will degrade the nucleus and the complete cell also. Okay, so that is what is happening in necrosis. When you study about necrosis itself, you should know what is apoptosis also. Okay, because both are like interrelated process, but there are like huge differences between both also. Okay, so necrosis means it is like cell injury is happening and cell is dying, whereas apoptosis means it's more like a programmed cell death. Okay, if the cell is too old, okay, then the cell itself will program for its death. Okay, so that is called as apoptosis. Or if you want to eliminate the unwanted cells, then apoptosis is happening there. Okay, so it is kind of a programmed cell death, more like a cell suicide. Okay, so in apoptosis, what is mainly happening is that the cell will shrink and the nucleus will undergo main changes, like the nuclear fragmentation will be happening, and all the contents of inside the cell will be converted into like apoptotic bodies. Okay, so these apoptotic bodies are nothing but they will contain the fragments of the cell organelles and all those things will be there in this apoptotic bodies and it will be released outside. Okay, so finally the apoptotic bodies will be like phagocytosed by any inflammatory cell. Okay, so that is the most common process that you see in apoptosis. Okay, so I hope you know the difference between this apoptosis and necrosis. So in the question, it is given like patterns of nuclear changes in necrosis. Okay, so even if you don't know the exact nuclear process that is happening inside the in necrosis, you can see that this pycnosis, karyorrhexis, and karyolysis are something related to nucleus only. But the cytoplasmic blebs, okay, cytoplasmic blebs are more like the what to say, like blister-like projections that is extending from the cell surface. Okay, like this. Okay, so these are the blister-like projections that is extending from the cell surface like this, and it is most commonly seen in the apoptosis. Okay, blebs will form like this, and which will get converted into apoptotic body, and necrosis and the phagocytosis will happen for apoptosis. Okay, so this cytoplasmic blebs are usually seen in apoptosis only. Necrosis contains all these other things like pycnosis, karyorrhexis, and karyolysis is same. Okay. Now, next question, we will discuss about what this pycnosis is, what this karyolysis is, and what this karyorrhexis is. Okay. So, which of the following statement is correct here? Pyknosis means shrinkage of nucleus, or karyolysis means dissolution of nucleus, and karyorrhexis means fragmentation of nucleus, or if all the above statements are correct. Actually, all the above statements are correct. So we had already had a look at the cytoplasmic changes that is happening in the necrosis, like the cell swelling, and there is like a pores of the cells, cytoplasmic membrane is happening, and all the contents are getting leaked out also. Okay, so that are the cytoplasmic changes happening in the cell. Now let's have a look at what are the nuclear changes that is happening in necrosis. So this is a normal cell with a normal nucleus. The three nuclear changes that is happening in necrosis is, one is pyknosis, second one is karyorrhexis, and the third one is karyolysis. Okay, so what do you mean by pyknosis? Okay, so as you can see, this is how a normal nucleus looks like. Pyknosis, what is happening is that the nucleus is getting shrink. Okay, you can see the size also between the normal nucleus and this pyknotic nucleus. The nucleus is getting shrink, and it's the contents of this nucleus are getting condensed. Okay, so DNA is getting condensed inside this pyknotic nucleus. Okay, so that will create a very like dark blue in color. Okay, so this dark blue in color, it is called as increased basophilia. Okay, so in pyknotic nuclei, one thing that you see is the nucleus is getting shrinked, and the DNA contents inside the nucleus is also getting condensed. So what happens is that it will produce like increased blue color for the nucleus, which is called as increased basophilia. Okay. Now, once the pyknotic nucleus is formed, then it will progress into something called as karyorrhexis. Okay. So what do you mean by karyorrhexis? The pyknotic nuclei that undergoes fragmentations like this. Okay. So this is called as karyorrhexis. Then the last stage is karyolysis. Okay, so karyolysis means all these fragmented particles are there, right? It will be digested by DNA's enzyme. Okay, so that is what is happening in the karyolysis. So at the end stage, we will not be able to see any nucleus at all. Okay, so these are the nuclear changes that is happening in necrosis. The next question, all are features of apoptosis except. Okay, so we had discussed the cytoplasmic changes and the nuclear changes related to necrosis. Now we are moving on to apoptosis. So all are features of apoptosis except, is it absence of adjacent inflammation? Yes. Fragmentation of nuclei? Yes. Disruption of plasma membrane? Is it C? Or shrinkage of cell size? So as I had already mentioned, sorry, so this apoptosis is programmed cell death. So what is mainly happening is that the cell size is getting reduced and the nucleus is also getting fragmented. Sorry. Sorry for the disruption. So here what is happening is that the cell size is getting reduced in apoptosis, and the nucleus is also getting fragmented into small pieces, and the plasma membrane, okay, that is the cellular plasma membrane or the outer covering of the cell, is not getting disrupted in apoptosis. Okay, in necrosis, I had already mentioned the plasma membrane is like disrupted, and small like holes are created in the plasma membrane, and the contents of the cell is leaking out. Okay, whereas in apoptosis, plasma membrane is intact, and only the plasma membrane is intact, only the apoptotic cytoplasmic blebs are forming and apoptotic bodies are getting detached from it. Okay, the plasma membrane as such is intact. Okay, and inflammation is like not that much seen in the apoptosis. Okay, so as if you look at the question, all are features of apoptosis except disruption of plasma membrane. disruption of plasma membrane is a feature of necrosis. Okay. Now, next question. A 70-year-old bedridden paralyzed patient was declared dead. On autopsy, which of the following type of necrosis is seen in the brain? Okay, now we had like discussed all about the cytoplasmic changes and the nuclear changes that is happening. Now let's like focus on what are the types of necrosis. So the types of necrosis that you will usually see are coagulative necrosis, liquefaction necrosis, caseous necrosis, fat necrosis, and fibrinonecrosis. These are the 5 types of necrosis, and there are specific sites where you see such necrosis. For example, like in heart, spleen, and kidney, you will be mainly seeing coagulative necrosis, whereas in brain and in case of abscess cavities, you will be mainly able to see liquefactive necrosis. In pancreas and breast, you will be able to see the fat necrosis. And in case of like ulcers or the arterioles in hypertension, mostly fibrinonecrosis is seen. And in case of TB infection, mostly caseous necrosis is seen. Okay, so this table is like really important because they can ask any clinical based questions related to this. Okay, whether the patient has like is suffering from what entamoeba histolytica infection. Okay, so what kind of necrosis is usually seen, like that and all, you can expect questions. Okay, in entamoeba histolytica, you'll be able to see like liver abscess formation. Okay, abscess cavities in the liver can be seen. Okay, so liquefactive necrosis is like that. You have to know like in which all clinical situations which all necrosis is seen. Okay, so in case of liquefactive necrosis, what is happening is that because of some kind of infection or some kind of like traumatizing agents, what is happening is that there will be lots of accumulation of inflammatory cells and the leukocytes. Sorry, the leukocytes will release lots of enzymes which will liquefy the brain tissue like this. Okay, so this is a gross picture of the liquefactive necrosis, and this is a histopathological picture of liquefactive necrosis. As you can see, the enzymes that are released from these inflammatory cells, they kind of like liquefy the tissue. Okay, so that whole brain tissue is getting converted into a viscous liquid. Okay, that's why it's called as liquefactive necrosis. And this tissue is further cleared by the phagocytes also. Okay, so this is what is happening in the liquefactive necrosis. You can see lots of inflammatory cells are in the area, and along with that granulation tissue and glial cells will also be there. Okay, since it's a brain, glial cells will also be seen. Next question: which of the following is not true of dystrophic calcification? Okay, okay, does it occurs in damaged tissue, or is it a tuberculous lesion, or is it an atherosclerotic lesions, or serum calcium levels are high? So which is not true of dystrophic calcification? This option D, serum calcium levels are high. So before moving on to the answer, let's discuss about what is pathological classification, what are the types of pathological calcification, and where you will see them also. So pathological calcification, which is also called as heterotopic calcification, it means abnormal deposition of calcium salts in tissues other than osteoid and teeth. Okay, so the like calcium salts getting accumulated in soft tissues. Okay, other than the osteoid and teeth, that is called as pathological calcification or heterotopic calcification. Now there are 2 types of pathological calcification. One is dystrophic and the other one is metastatic. Okay, so in dystrophic, what is happening is that the calcium salts are getting accumulated in dead and degenerated tissue. Okay, and in metastatic calcification, what is happening is that because of some kind of a metabolic disorder, okay, so these calcium salts are getting mobilized from bone, and they are getting accumulated in specific soft tissues, or they can be mobilized from the intestine also. Okay, and they are getting accumulated in specialized soft tissues. Okay, so this is how, like in a histological view, you will be seeing calcifications as. Okay, so this is a blood vessel. So you can see this dark pink colored ring-like structure. Yes, that is the calcium getting accumulated inside the blood vessels. Okay. So let's see the main differences between this dystrophic calcification and metastatic calcification. In dystrophic calcification, like I had already mentioned, the deposits will be in the dead and degenerated tissue, whereas in the metastatic one, it will be in the normal tissue. Okay. Calcium metabolism will be normal in case of dystrophic calcification, whereas it will be deranged in case of metastatic calcification. And the calcium levels are also normal in case of dystrophic calcification, whereas you will be able to see hypercalcemia or increased calcium serum levels will be seen in metastatic calcification. Okay, dystrophic calcification is usually irreversible, whereas metastatic calcification is usually reversible. Okay, where else, in which all situation you will be able to see this dystrophic calcification is in case of some kind of necrosis, like the caseous necrosis or liquefactive necrosis or fat necrosis. You will be able to see this this dystrophic calcification, and in some kind of calcinosis cutis, in atheromas, in hematomas also you can see. Whereas metastatic calcification is more common in metabolic diseases like hyperparathyroidism or myeloma, hypervitaminosis D, milk alkali syndrome. In that and all, you'll be able to see metastatic calcification also. Okay. So that is the main differences about this dystrophic calcification and the metastatic calcification. So among the given options, it is specifically given like the serum calcium levels are high for dystrophic calcification, which is not true because serum calcium levels and the calcium metabolism is normal for a dystrophic calcification. Let's look at the other options also. It occurs in damaged tissue. Yes, the dystrophic calcification occurs in dead and degenerating tissue. Tuberculous lesions. Yes, where there is caseous necrosis in, it can like show dystrophic calcification. And atherosclerotic lesions also. Yes, it can be seen in atherosclerotic lesions also. Okay. Next question. Some of our bodies are associated with, is it metastatic calcification or dystrophic calcification or apoptosis or necrosis? Where you will see them. This option B, dystrophic calcification. Yes. So let's see what is Samoma bodies are. Samoma bodies are round lamellated microscopic calcifications like this. They are considered as a form of dystrophic calcification. Okay, they sometimes resemble the grains of sand also. Okay, so these Samoma bodies are seen in a lot of pathological conditions, and some of the conditions are given here, and there is an easy way to remember the lesions where you see Samoma bodies. Just remember the mnemonic most PG. Okay, so just remember this mnemonic most PG. Most PG means meningioma and mesothelioma and papillary carcinoma of ovary, papillary carcinoma of salivary gland, and papillary carcinoma of thyroid. All the papillary carcinomas, the ovary, salivary gland, and thyroid gland, you can see, and prolactinoma and glucagonoma. Okay, so these are some of the pathologies where you will be able to see Samoma bodies like this. Okay, so remember this mnemonic, most PG. Okay, next question. The metastatic calcification is absent in. Okay, where I think you already know the answer. It will be present in metabolic disorders like hyperparathyroidism, in chronic renal failure also it can be seen, and in malignancies also it can be seen. So the one where it is not seen is caseous necrosis in TB. In caseous necrosis, usually what you'll be able to see, dystrophic type of calcification is seen. Okay, remember that. Now next question, which of the following statement about fibrinous exudate is false? It is associated with many types of severe inflammation, or it has low protein content, it has fibrin precipitates, and it has low glucose content. Okay, so for that, you should know what you mean by exudation, then what you mean by exudate, transudate, what are the types of exudation. We'll discuss all those related to that. So escape of any fluid or any protein or any blood cell from the vascular system to the outside. Okay, that is called as exudation. That process is called as exudation. It can be fluid, it can be cell, or it can be proteins also. If something is escaping from the blood vessels to the outside tissue, that is called as exudation. Now, this exudation can be of two types. There will be exudate and transudate. Okay, based upon the properties of the fluid that is present outside in the interstitial space, it can be exudate or transudate. Okay, so the exudate is more like a, what to say, the an example of pus can be seen. Okay, so pus is like a main example of exudate. Like the because of the increased permeability of the blood vessels, what happens is that the fluid inside the blood vessels is getting leaked to outside, and the outside fluid, the fluid that is leaked to outside, that particular fluid will have high protein concentration and will contain lots of cellular debris. Okay, so if that particular interstitial fluid contains high protein content and it also has high cellular debris, then it is called as an exudate. Okay. If the fluid that is outside in the interstitial tissue has low protein content and no cellular material and low specific gravity, then that is considered as a transudate. Okay, so a transudate is more like an ultrafiltrate of blood plasma. Okay, so that is the main difference between this exudate and transudate. Okay, so let's see how this exudate and transudate is happening. So this is a normal blood vessel with normal hydrostatic pressure and normal colloid osmotic pressure. In exudation, for exudate formation, what is happening is that some kind of inflammation. In case of some kind of inflammation, what is happening is that there will be this spaces between the endothelial cells will be more. Okay, so increased interendothelial space will be seen. So what is happening is that the fluid and the cells and the protein is going outside. Okay, so fluid and protein leakage is happening. So the contents will be going outside. That will create a exudate with high protein content, and sometimes cells can also be seen. But in transudate, what is happening is that the hydrostatic pressure is getting increased, like in case of like congestive cardiac failure, or because of the decreased colloid osmotic pressure. For example, like in liver or kidney disease. So because of these conditions, what is happening is that the fluid is getting leaked to outside of the blood vessels, which will produce a transudate with low protein content and very few cells. Okay, so I hope you know the difference between the exudate and the transudate. Just remember these diagrams. The hydrostatic pressure and the colloidal osmotic pressure, if it is like balanced, then the fluid and all the cells will stay inside the blood vessels. If there is disruption because of some inflammation or because of some like congestive cardiac failure or because of like liver or kidney disease, then only this exudate and transudate is happening. Okay, so this table is also very important. The differences between transudate and exudate, and as you can see, the protein content is usually high in case of exudate, and the glucose content is low. Okay. So there are, if you look at the types of exudate, there is like serous exudate, which will be usually watery, which you can see in the pleural effusion in TB and in burns also. Fibrinous exudate is also there, which is you will be mostly seeing in the pneumococcal and the rheumatic pericarditis. Purulent and suppurative, the pus. Okay, that is the and the abscess and the acute appendicitis and all. You'll be able to see the pus. Okay, that is the purulent or suppurative exudate and hemorrhagic exudate. Because of a vascular damage, you can see the hemorrhagic exudate also. Then catarrhal exudate, the one that we see in common cold and all because of the increased secretion of mucus. Yes, that is catarrhal exudate. Okay, so these are the 5 types of exudates: serous, fibrinous, purulent, hemorrhagic, and catarrhal. Yes, next question. The process by which red blood cells move out of vessels through widened interendothelial junction is referred to as, what is it called? Is it pavementing, or diapedesis, or rouleau formation, or chemotaxis migration? So they are talking about RBCs, not neutrophils. Okay, you should know that they are talking about RBCs and not neutrophils. So pavementing, this chemotaxis migration, both these terms are associated with neutrophils only. Okay. RBCs, diapedesis and rouleau formation is mostly associated with RBCs. Rouleau formation means it is like the RBCs are getting stacked one above the other like coins. Okay, so that is what is called as rouleau formation. Okay, so the remaining option that is left is diapedesis only. Now let's see what is happening. Okay, so inflammation. To understand about this pavementing, diapedesis, and chemotaxis migration, you should have an idea about inflammation. Okay, so inflammation. What do you mean by inflammation? Inflammation is considered like a local response of a living tissue to any external agent. Okay, it can be an injury or it can be a bacteria or like some kind of microorganism also if it is causing an injury, and some kind of a local response of the living tissue towards the outside agent. Okay, it is mostly considered as a like a response by the body to protect the body. Okay, it is considered as a defense reaction actually. Okay, so this inflammation can be of two types. We have acute inflammation and chronic inflammation. In acute inflammation, the two main events that are happening is the vascular events and the cellular events. That is, there will be changes in the blood vessel structure, and like hemodynamic changes or the permeability changes can be seen, and there will be changes in the cells also. The cells inside the blood vessels can go outside and will produce like more and more reactions outside the blood vessels also. So that is called as the cellular events. Okay, so we have the vascular events and the cellular events. Okay, so in case of some kind of injury to our skin or to a particular structure, what is mainly happening is that the initially a transient vasoconstriction will be there. That is, the blood vessels will constrict. Okay, but then later on, what is happening is that there will be progressive vasodilatation. Okay, the blood vessels will dilate. Okay, so if you look at the normal blood flow in a blood vessel, you will be able to see that these red color cells like structure that are seen. Yes, these are the endothelial cells. These are the endothelial cells, and this is inside the blood vessel. So usually the cells, whether they are RBCs, WBCs, or the platelets, they will be usually going in the center of the bloodstream. Okay, and at the periphery, you have the plasma. Okay, so this is how the normal traveling is happening inside the blood vessels. Centrally, there will be cells, RBCs, WBCs, or platelets, and peripherally, you have the plasma. Okay, but in case of this inflammation or because of this injury, what is happening is that because of this vasodilatation is happening, what happens is that there will be stasis of blood. That is, the blood flow is like getting slowed down. Okay, so when it gets slowed down, what is happening is that these cells that are there in the center of the flow, it will start like getting more and more closer to the endothelial cells. Okay, so it will start like rolling through the endothelial cells. Okay, so that is called as the rolling phase. Now the neutrophils that is getting distributed close to these endothelial cells. Okay, so this neutrophil starts getting close to these endothelial cells. That is called as pavementing. Okay, so that is called as pavementing. Okay, they will first the neutrophils start getting distributed close to the vessel walls, and then what happens is that there will be a bond created between this neutrophils and the endothelial cells. Okay, a bond will be created between this neutrophils and the endothelial cells, which is called as the adhesion phase. Okay, so the rolling and the adhesion phase. First, it will start rolling over the endothelial cells. That is called as the rolling cells. Then it will get pavemented, and then it will move on to the adhesion phase. Now, after the adhesion phase, what happens is that these neutrophils will get escaped to the outside. Okay, through the gap between the endothelial cells, these neutrophils will move to outside into the interstitial tissue. Okay, so that is called as the immigration. Okay, so the escape of the neutrophils outside into the interstitial tissue, that is called as immigration. Okay, now along with neutrophils, sometimes some RBCs can also escape to outside into the interstitial tissue, that is called as diapedesis. Okay, so we had discussed about the margination, fermenting, rolling and adhesion phase, then immigration. Immigration is only the neutrophils going outside. Okay, if it is the RBCs going outside, then it is called as diapedesis. Remember the names. Next question. Actions of bradykinin include all of the following except. Is it vasodilatation or bronchodilation or increased vascular permeability or pain? Okay, so in the last question, we had discussed about the events that are happening in the inflammation. Okay, mainly the acute inflammation. Now, there are certain chemical factors or chemical mediators that are helping in this endothelial contraction or vasoconstriction, in vasodilatation, and in producing other systemic effects of inflammation. Okay, so they are called as the chemical mediators of inflammation. Okay, so these chemical mediators can be produced from cells like the mast cells or platelets or some kind of inflammatory cells like neutrophils or macrophages can all release its mediators. Okay, so they are called as, they can be cell-derived mediators. That is the ones that are produced from the cell. Okay, and then we have the plasma-derived mediators, the ones that are produced from the plasma. Okay, so cell-derived mediators are the common ones like the histamines, arachidonic acid metabolites, free radicals, cytokines. The major ones are all cell-derived mediators. Then we have the plasma-derived mediators also. Then we have the kinin system, protein, fibrinolytic, and the complement system. So if you look at this kinin system, it is where the bradykinin is formed from the factor 12. Okay, so this is the pathway of formation of bradykinin from factor 12 in the presence of this prekallikrein activator and all. So if you look, this is the main mediators of inflammation, and their source and their actions are given in this table here. So if you look at the kinins, it is produced from the plasma and produced in liver. It is actually produced in the initial stages of inflammation and mainly helps in increasing the vascular permeability, in smooth muscle contraction, in vasodilatation, and in pain. Okay. So out of the options given, vasodilatation, yes, it is a function of bradykinin. Increased vascular permeability, yes, that is also an action of bradykinin. Pain, yes, that is also an action of bradykinin. But bronchodilation is not an action of bradykinin. Okay, so who else brought this bronchodilation? It is mainly the arachidonic acid derivatives. Okay, so the arachidonic metabolic acid metabolites, they are the ones, especially the PGD2, especially the PGD2, PGE2, and PGI2. Okay, they are the ones that are most commonly involved in bronchodilation. The next question. The persistence of epithelial cells after wound healing gives rise to. Okay, so for this, you need to know the complications of wound healing. Okay, so is it implantation cyst or keloid or wound dehiscence or cicatrization? So if the epithelial cells are persisting even after wound healing, it will give rise to an epidermal cyst or implantation cyst. Okay, so for that, you should know the complications of wound healing. Infection is a common complication of wound healing. Next is this implantation or epidermal cyst formations like this. Okay, so because of the persistence of epithelial cells, even after the healing of the wound, you'll be able to see such cyst-like structures. That particular region, that is called as the implantation cyst. Then pigmentation, that is like because of the accumulation of hemosiderin pigments, pigmentation can be seen in wound healing. Deficient scar formation because of decreased collagen formation or something like that. Deficient scar formation can be seen. Wound dehiscence or incisional hernia, because of a weak scar, there will be bursting open of a wound. Okay, so that can lead to wound dehiscence or incisional hernia. And hypertrophied scars like this. Okay, so this is an example of a hypertrophic scar, and this is an example of a keloid. Okay, that is because of accumulation of excessive amounts of collagen. Okay, so excessive amount of collagen accumulation in the scar area can result in a hypertrophic scar like this. Okay, if the this particular scar, like pigmentation is produced beyond the boundaries of an original wound, then it is called as a keloid. Okay, so that is the main difference between the hypertrophic scar and the keloid. If the scar tissue is forming in the particular region of the scar, then that is called as hypertrophic scar because of the increased amounts of collagen. But if it is forming at a place that is away from the scar, then that is called as keloid. Okay. So scar tissue beyond the boundaries of the original wound, that is called as the keloid. Okay, then cicatrization. Because of the exaggeration of the wound contraction, cicatrization can also happen. And last one is neoplasia. The best example is Marjolin's ulcer. Okay, squamous cell carcinoma arising from Marjolin's ulcer. That is an best example of the neoplasia arising from a wound. Okay. So, yes, in case of any doubts, you can ask now. Or if you don't have any doubts now, then you can comment below this video. We'll definitely answer all your doubts. And yes, Dr. Nikhil Singh, we are coming up with a recall session for general pathology and microbiology soon. Okay. And we are also coming with the live sessions of the next classes for this general pathology, mainly the fluid and hemodynamic disorders and the diseases of blood and lymph node we'll be discussing soon. Okay. So in case of any doubts, you can comment below this video. Okay. And yes, we'll be coming soon with the recall sessions of the NEET MDS 2025 general pathology and microbiology questions also. Okay. Okay. So I think that's all for today. All the best for your preparations. Do well. Thank you so much for attending the session. Thank you. Goodbye and good night.